Welcome to you all. It's good to see everyone again, and I'm sure more people will continue streaming in. So, today we're going to talk some about reading X-rays relating to the musculoskeletal system. You guys got some on reading X-rays as part of CS2, right? With the cardiovascular system and respiratory system. Talked about chest X-rays. So a lot of the same principles apply, but want to apply them a little differently. So this is a reminder for me to congratulate you guys. You're getting really close to the time when you put on stethoscopes and white coats and all that kind of stuff. And so we need these types of practical skills, right? That's the goal of this course, is to get you guys ready for being with patients all the time. So this is my youngest daughter pretending to be a doctor. All right, so key points, which would be really similar to what we talked about with the chest X-ray. I guess overall, what I would say is just remember, I had a friend in America who always used to say that reading an X-ray or reading an EKG or reading lab work or a blood gas is a moral endeavor. Like it's an ethical undertaking. Because it's not just a picture, right? It's a picture of a human being with a life and issues that we're trying to help. And we always want to remember, especially when if you're a radiologist and you're looking at pictures all day long, sometimes you can forget that there's a patient on the other side of that X-ray, right? So always remember, when we're reading X-rays, one of the reasons we do these things with excellence is because God created human beings. Therefore, human beings are super valuable, and we should take really good care of them, and we want to do our best, whether it's reading an X-ray or an electrocardiogram or taking a history or doing a physical examination, right? We're going to do our best because we've got this God-given responsibility. Okay. So, plain radiographs, this will tie in very much to your anatomy and applying that to what you'll see on the picture. What do we see? It's a way to look at the bones and the joints for sure. Don't forget that it's a way of looking at the soft tissue as well. We think of X-ray as showing bone, and it does, but the soft tissue is visible as well, right? Not as visible, not as obvious, but still we can learn something about the soft tissues. Be systematic, okay? It's not a strength of doctors in general worldwide. It's definitely not a strength here when you see doctors plying their trade. Just like, again, worldwide it's an issue. But you want to use a system because we don't want to miss anything, right? It's very easy to get distracted by the horrible fracture on the right side and miss the apical lung mass that's lung cancer just across from that, okay? So we're going to be systematic. We're going to get all of the information the X-ray has to offer because, again, we care about people. And this is a picture of a human being, albeit a strange picture. So we'll talk about how do you be systematic. Look at all views available. You'll notice I put in big letters, look. So if you order an X-ray, look at it. Even if a radiologist is going to look at it. You look at it. If you ordered it, you look at it and make sure you have read it. Why? Radiologists miss things. And again, you're the one who knows the history. You're the one who knows why you ordered it. You know what you're looking for, right? So you have an advantage over the radiologist because you actually laid hands on the patient and heard the whole history. He's seeing the patient for a few seconds, maybe not at all. Maybe the tech took the picture and he's only seeing the X-ray later in whatever history you wrote on the request. So, if you order a film, and this goes for lab work, it goes for electrocardiograms, anything you order, you need to see the result, okay? Also, if there is a report from a radiologist, and it's not the final report. Always make sure you go back and read the final report. Sometimes the reports change, and if you operate off of a preliminary report, again, you may miss things. Patients can be harmed, okay? Things get missed all the time. Cancers get missed. Fractures get missed that could have been repaired and saved the patient a lot of pain and suffering. Big things, okay? So, all that to say, actually look at the pictures if you order them. Or if your patient has an x-ray, don't just read the report, look at the pictures for yourself, okay? And that's going to apply to a lot of things, but especially to this. Also, look at all the views available. So this is an encouragement to make sure that the right x-rays are done. So you as the ordering person, you're going to almost always, with the musculoskeletal system, need at least 2 views, right? You'll need an AP view, like an anterior-posterior view, and also a lateral view, because that's giving you a 3-dimensional picture of the bone, right? If you have bone overlaying bone from the AP view, you might miss a fracture that's very easy to see if you have the lateral view, okay? And in some cases, it won't be a lateral view and an AP view. It'll be an AP view and an oblique view. That's all stuff you can learn when you're on your rotations. But again, get multiple views and look at all of them. Okay, I've belabored that enough. I have a teacher from my medical school who was a radiologist who used to say the most important x-ray is the old x-ray. Why? Because we want to be able to compare. How do we know if something's new or not? We look at the old x-ray and we can see whether it was there before or not, whatever lesion, whatever abnormality we're seeing. It's also been called the cheapest test in radiology, the old x-ray, right? Because it's already done, already paid for, but it's giving you good information. So remember that. If there is an older x-ray, go look at it to compare. All right? It's similar when you look at the body. You want to always compare side to side, right? There's symmetry. And so it's helpful to compare side to side. Abnormalities aren't always obvious, but if you see that things are dramatically different from one side to the other, that's a clue that something is wrong. Okay. Always assess image quality. And if it's poor quality, don't read it. Get a new image. Again, because it's important. It was important enough to order the x-ray. Make sure it's done correctly, right? Don't miss something because the film is poorly penetrated or the patient wasn't positioned properly. You know, this kind of thing, right? And you guys talked about some of that again with the chest x-ray last semester or last spring. And then the last thing, practice. Practice. So I said look at all the x-rays. Not just look at them, but also practice these skills we're going to talk about today. Why? Because that's the only way you'll ever get good at this. It's the only way you'll ever become accomplished at reading x-rays. It's just to read lots of them. And then once you've read it, compare what you see and what your reading was to what the radiologist's reading was or what the more experienced doctor's reading was. Okay? So practice. This is true for all of your clinical skills, right? We're giving you a foundation, and what's really difficult is you guys don't have a lot of opportunity to practice these skills. Where are you going to practice them? Ideally, we'd have you with patient some right now practicing. And you can practice with your friends or your family members or your neighbors, but soon you guys will be in a clinic or in a hospital. And even if other people around you aren't doing a thorough physical examination, you do the thorough physical examination because you guys know how. And it's the only way you'll become really good at it. It's just to do it over and over and over and over again. I learned how to listen to lungs say really well, I felt like. But then when I rotated for 1 month on a pulmonology service, a lung doctor service, I was hearing all sorts of things I had never heard before and really putting my skills to use. I knew what crackles were, and I knew what dullness to percussion sounded like, and I knew what wheezing and stridor and all of these things sounded like for my own ears, right? So practice these skills. Practice these x-ray skills. Practice EKG reading skills, all the things we've taught you, because that's when you'll become truly good at it. All right, so this is the first x-ray ever done on someone's hand by Röntgen a long, long time ago. But, basic anatomy. So what is the goal of talking about x-rays? You want to know how to describe things, right? If you can describe what's on the picture accurately, that will give you the diagnosis, okay? And again, you guys have an advantage. You will have the history. You will have the examination. So a lot of the time, you know what you're looking for, and so you're just looking for confirmation, and the x-ray helps give you that, okay? But you do want to know how to describe things so that whatever you see and you record and write down, other doctors can understand and go look and see the same things, right? So we use the anatomy to help us describe. So especially when you're talking about younger patients, before they've had full formation of the bone, right? They're still developing. It's important to know. Some of the words got chopped off. That's okay. You have the diaphysis, right? That's the word that got chopped off. That's the long shaft of the bone, okay? And it is separated. You go to the metaphysis, which is the end of the bone, right? And then you have the growth plate, the physis, we call it sometimes. Maybe you guys have called it in your lectures up to this point. And the epiphysis, which is the joint-facing part of the bone, which again is separated from the metaphysis and diaphysis by the growth plate. All right? So you might say in a child, they have a epiphyseal fracture. In other words, a fracture across that part of the bone. Okay? You might have a fracture across the growth plate or through the growth plate. Okay, those have a different name. Those are called Salter-Harris fractures. They have a classification system for those. But nonetheless, you have the patella, which is a sesamoid bone, right? And you'll see those around other parts of the body. Apophysis, it's a bony outgrowth where very often a tendon will be inserting. So here you have the patellar tendon as it inserts into the anterior tibia, right there at that apophysis. So again, this helps you describe where on the bone is the problem. So you want to know this basic anatomy so that you can describe to someone else, where am I seeing the problem? And again, describe for yourself because it affects the diagnosis, which will affect what you do for the patient, right? If you have a fracture across the growth plate, that's a much more complicated problem than just a fracture of the diaphysis, the shaft of the bone. As people get older, those distinctions are less important. So we use different terminology sometimes. You could use the same terminology, but it's not as obvious once the growth plate fuses and you're left with the bone. And we're talking about specifically long bones here. We're not going to get into every aspect of musculoskeletal radiology. We don't really have time. It's not really important for you guys at this stage to talk about all the different types of bone. We're going to focus more on the long bones. But nonetheless, all of these things basically apply to other parts of the body too. So we might instead talk about the proximal bone, the part closest to the rest of the body, the distal bone, the part furthest away from the rest of the body. Typically the proximal part, what would have been the epiphysis and metaphysis, we'll call the base. And then you have the shaft, and you have the neck and the head at the distal end, right? And you have a distal articular surface and a proximal articular surface. But proximal, distal, head, neck, shaft, these are all things that you'll hear when you talk about adult fractures. Okay, so your systematic checklist. This is where we're going to talk about being systematic. In the same way that you had a system for looking at chest x-rays to make sure you didn't miss anything, we also need to have a system for looking at any other x-ray to make sure nothing gets missed. So the first thing is the patient and the image details. You want to make sure that it's the right patient on the right date at the right time. Okay? Sometimes multiple x-rays get taken in a day. And it might be before and after there was some stabilization of the fracture, or when there was a reduction of a fracture. You might have before and after pictures. You want to look at all the pictures and make sure the time you're looking at on the x-ray is the time you're expecting to see. So you want to make sure it's on the right patient, on the right date, at the right time, and it's on the right side of the body. So this is not about x-rays, but I had a patient one time who came to me with pain in his right arm. He said he was hitting a ball with a bat. We like baseball and softball in America. And he felt a sharp pain, and suddenly he couldn't swing the bat anymore. So a colleague of mine ordered an MRI of the shoulder. And the MRI showed nothing. It showed that he had a healthy shoulder. Well, on physical examination, I could see the tiny ball of his biceps muscle that had separated and was now balled up at the base of his arm near the elbow. And that's because he'd had a rupture of the biceps tendon. But his shoulder MRI looked fine. Why? Because they were looking at the wrong joint. Okay? So we want to make sure it's the right joint, the right side of the body. The sides are symmetrical, right? Right and left can look very similar in x-ray, because I have to just flip it around and get the mirror image. You want to make sure you're looking at the right side of the body. Okay. Bone and joint alignment, we'll talk some about that. Joint spacing, we'll talk some about that. The cortical outline, we'll talk about the cortex, and which is the outer, hard layer, and then you have the medullary layer in the middle. Bone texture, do they have osteopenia, osteoporosis? Is there any disease of the bone itself that might be causing a pathological fracture? And then remember, look at the soft tissues, right? Don't think of x-rays just as a bony study. It is that, but you also can note something about soft tissues as well. All right, so the patient and the image details. So just make sure, again, right patient, get the name, the date, the time, what side was pictured. So I couldn't find a good example of the plate, but you always want to look for something like this. In this case, we'll call it patient DT. But you always want to have the name and the date and the side listed on the film. You always want to read that part. And I could not find one of just a generic patient on the web, but of course these pictures are everywhere, so that was easy to pull. I'm American, I can make fun of him, right? All right, so bone and joint alignment. So who sees the problem here? How are you going to describe that to me? Right, and so if I were on my iPad or my laptop, I could use the little laser pointer thing. Let's see. Anyway, you guys can see right here, right, that there's a definite problem with the bone and joint alignment, right? At the joint, you have a lateral displacement. And that's a problem. That's not normal. And you can even say that it's more obvious and more pronounced because you're looking at all of the other joints and bones and seeing that they're all aligned. So yeah, that's a clue that there's pathology there, right? When the bone and joint alignment is not correct. So that you're always looking for that. Every film, after you check and make sure it's the right patient and the right date and time, right side, you're going to look at, are things lining up? And that principle will apply no matter what part of the musculoskeletal system you're looking at. Whether you look at the cervical spine because someone's had a head and neck injury, whether you're looking at the fingers, the arms, the legs, you want to check for that. Okay? So the next thing we're going to talk about is joint spacing. And you guys will notice there's a big difference between the tarsometatarsal joint, the first tarsometatarsal joint over here, and the rest of them, right? Any idea what this patient might have? I don't know if you guys have gotten that far in the musculoskeletal system yet. There's a particular disease that tends to affect this joint with arthritis more than the others. So, what? Yes, gout. It's called podagra, or the classic presentation of gout at the first tarsometatarsal joint. So, you notice that there's narrowing of that joint space, right? And it's not like the others. Again, I'm comparing to all the others and seeing this is different, this is abnormal. So you see the joint narrowing. You also see these osteophytes forming, and that's a response to inflammation and injury. It's a classic thing that happens with arthritis, is you get osteophyte formation, extra bone being produced. So yeah, joint spacing you're always going to want to look at. The cortical outline. This one's super important if you're looking for fracture. We think, oh, fracture, that's easy to see. Not always. Not always, right? So what you do literally is you can trace the outline of each bone and make sure everything's lining up. So if I do that with this particular x-ray, where do I run into a problem? The fourth one, right? Yes. And so there clearly is a break. But that's not super obvious. If you're just quickly looking at a film, you could miss that, right? You could especially miss it because you see these outlines over here. And that happens, right? Sometimes the radiologist will mark something somewhere else on the film, and so you don't look at the things that aren't marked. But in this case, there's a fracture there. Okay? So always check the outline of the bone to make sure the cortex is not fractured. All right, so this one's a little bit more complicated and a little bit harder to see, so I left the highlighted images up there. You want to look at the bone texture, okay? So some of that depends on the technique. You want to make sure that there's adequate penetration on the film, but not too much penetration, so that the bones show up nice and white. But sometimes the reason they don't show up nice and white is because they have osteopenia, right? There's not enough bone calcified material there to give a normal appearance on X-ray. There's also a situation where you could have diseases that cause the bones to lose. Say, multiple myeloma is a situation where you might have what they call punched out lesions, like holes in the bone, basically. And of course, that predisposes to fractures, pathological fractures. You could have benign lesions of the bone, cysts and things like that that could predispose to fracture. The other thing you can look at, and it's like I said, it's really hard to see on the screen at the front of the room, but there are these normal lines that you see. And again, we talk about trabecular bone and how it's laid out. And again, you guys will get all into that in terms of your other classes, I'm sure, during the musculoskeletal system lectures. But you're looking for some of these normal lines, these trabecular lines in this case, and if there's any distortion of those, that's a clue there might be a fracture that isn't obvious otherwise. Okay? So if that line isn't straight, but it's more of a zigzag, or if a couple of them side by side are more of a zigzag, they're distorted, that distortion, that change in the trabecular pattern is an indication there's disease of the bone, maybe a fracture you can't see. Because we think of fracture as a big black space in the bone, but again, it's not always that obvious, okay? Let me just say something else while I'm thinking about it so I don't forget about it later. You will have patients sometimes where you order an X-ray and they go away and you say there's no fracture, and they go away and you feel very good about that. And then they come back to you in 1 week and say, oh, doctor, I'm still having the same pain I was having before. It hasn't gone away. It hasn't gotten better. What's wrong with me? This happens a lot in Jordan. It happens some in America, but this happens a lot here. I've seen it many times. The doctor says, oh, you're fine. We've already done an X-ray. You're fine. Go home. Well, but what's the problem with that? Why is that a problem? So they're still in pain, right? They haven't gotten better. Would we have expected them to get better from a relatively minor soft tissue injury after a week? Yeah, we would. We would. Okay? So that's an issue, especially if there's point tenderness. If you push on the bone, they're, oh, that kills me. So what should you do in that case? You've already done an X-ray. What should you do now? Anybody would boldly want to take a guess? Yes? Yeah, absolutely. Absolutely. It's never wrong. I mean, we worry about radiation, obviously, ordering a lot of X-rays. But in truth, X-rays are not that bad. CT scans, they're a little worse. That's like getting 250 X-rays if you get a CT scan, say, of your brain or your chest. So an X-ray is radiation, but it's not a whole lot of radiation. And to do one extra film, to be sure. And what happens? Very often what has happened is you couldn't see the fracture on the first film, but now that a bony callus has started to form after several days, you'll see, oh, that's where the fracture was. It just wasn't clear on the first X-ray. Okay? And so now you know, hey, I'm dealing with a fracture of the bone. I need to treat them accordingly. Immobilize the joint above and below the fracture, that kind of thing. So again, just when patients, this applies generally. I think there's a tendency here, more so than other places where I've worked. Once you've done the initial workup, if the patient is still having the problem, you can't just say, well, we already tried to figure it out and we didn't see anything, so go. No, because time is we call it a tincture of time. In other words, it's like a medicine. Time is like treatment in a way. Your body heals itself from so many different things. So time tells a lot. If someone is still hurting after a week when you thought they might have had a bony injury, that's an indication that there really was a bony injury and I need to go back and look for it. Okay? And even if you don't do that, please treat them with compassion. Please deal with their pain. But in that case, please do a repeat x-ray. Sometimes you have to repeat the lab work. Sometimes you have to do another history and another physical examination to see what's changed from before, to see what new information might come out. But again, just because you've tried to solve a problem one time and you didn't find anything, that doesn't mean you didn't miss it. And missing it may not be your fault. Like, that's not a problem, right? Fractures get missed all the time on the initial x-ray that become evident only on a later x-ray. It happens. It's not something you can avoid. Usually somebody with appendicitis, say, again, this is not musculoskeletal, but it frequently gets missed for a little while before the diagnosis is finally made. Because why? That disease entity evolves and changes as time passes. So the same is true for fractures. Yeah, I just see it a lot where people get turned away. Oh, we already worked on this. We already tried to figure it out. This is your diagnosis. We're not going to do any more work on this. Please don't do that, because time helps you. Time helps you get to the right diagnosis. It's a tool. It's like a treatment. It's like a medicine. Sometimes waiting will resolve the symptom. Sometimes it won't, and it's an indicator that I need to keep working on what's going on. Okay, that's my soapbox for that. Sorry. Look at the bony texture after you've looked at the cortical outline and the joint spaces and the alignment of the bones and the joints and the patient data. Okay, soft tissues. So what do you guys see here? So again, remember, we're not only looking at the bones on an x-ray. We're also looking at the soft tissues. So anything here stand out to you guys? So let's just go through the process, right? This is a good opportunity to practice a little bit. I'll tell you some more resources where you can practice when we're getting closer to the end. Because, again, one 50-minute lecture, and then maybe we'll even get done early if we're really good, it's not enough to become really good at reading x-rays, but it's enough to get you started, to give you some skills so that you can go practice, whether it's online or with actual patients down the road. So, in this case, we don't have the patient data. That's my fault. I should have put some stuff up there. So let's assume we're looking at the right patient and the x-ray was done on the right day and at the right time. It's the side we actually wanted to look at. Okay, let's assume that. What's the next thing we want to look at? Yes?
Can you go back to the previous picture?
The previous picture, yes? I think I can, yes?
Do we see this line is normal condition?
Yes, that's normal. You should see that. You should see those trabecular lines. And it's hard to see on the screen. It's easier on a computer screen if you're sitting right in front of it. So I left these highlighted lines because they're fairly faint on the x-ray. But yes, you should normally see that. And what you would be worried about is if they weren't straight lines or normal curves, but if they were distorted, like more of a zigzag pattern. But yes, that's normal. Let me say this too. There are a lot of lines and things on an x-ray. Sometimes something will look like a fracture and it's a normal variant. Like there are all sorts of things that can mimic fractures. One thing is like a blood vessel. Right? So if you have a blood vessel cutting across the bone at just the right place, you can be fooled into thinking that's a fracture, when in truth it's just a nutrient vessel for the bone. So that's where, again, this practice and seeing a lot of them really helps you. There are some clues to tell you it's not a fracture, but yeah. Again, we won't get into everything, but just know sometimes something that looks like a fracture isn't, and sometimes there's some lines in the bone. The question is that normal or not? I should have made that more clear. That's normal, and there are other things like Harris lines will cut across the bone. It's like a calcified line. It can look like a compressed fracture in a way, but again, they're normal. And once you know they're there, you know how to distinguish those normal lines from the abnormal ones. Yes, that's a normal pattern. If there's a distortion of that pattern, that's when we worry about fracture or disease. All right, so back to this one. So patient data is correct. So the next thing we want to look at is the bone and joint alignment, right? So what joint are we dealing with here? Yeah, the knee, right? So the patella there is a good clue. We're dealing with the knee. But again, that's tough. Usually an x-ray is a bigger picture. I tried to magnify it so we could see the things we wanted to see. So this is a little harder than a normal x-ray because you don't have as much context. You don't have as much of the bone on either side, that kind of thing. So The bone and joint alignment, to me, looks pretty good, right? And this is where, again, comparison side to side can help you. But I don't see any major problem there. What else do you want to look for? And the joint space doesn't seem overly narrowed. The cortical alignment, everything seems to line up pretty well. The quality of the bone, it looks like it's appropriately calcified. I don't see any disease of the bone. One thing you could miss, and you guys could, it may not be easy to see from where you're sitting, is when you do this line around, as I go past this area, I notice this little lucency here. And that actually does look like a fracture there. Okay, and it's tough, I'm sorry. I'll put these slides, I'll put the lecture online on Moodle so you can go back and review it later, and also talk about other places you can go learn more. But there is a fracture here, which is probably hard to see from where you're sitting. So one thing that can indicate that there's a fracture that's hard to see is the soft tissue abnormalities. So normally, just to the right of the kneecap, you see that black space there? Typically, fat shows up like that on an x-ray. And sometimes what's the indication that there's a problem is that the fat pad is elevated, right? So this black space normally should be laying down flat, but in this case it's elevated. And really, there shouldn't be this area. Again, I wish I brought a better pointer. But this area here below the black, that's the fat pad, should not be there. That's actually a fluid collection. And in this case, it's probably blood, because fat doesn't show up like that, but fluid does. And you could say, well, maybe it's pus. You could say that. But on history, in this case, you'd know that there was trauma to the leg. So when you go to look for it, we've looked at all the bone. You may miss that fracture, which is not super obvious. But whenever you have bleeding into the joint, well, that's a problem. Like, that's not normal. And so, again, it prompts you to go looking. Sometimes the only evidence you'll see on the x-ray of a fracture is that fat pad elevation or bleeding around the joint. And you'll need something more detailed, like a CT of the bone or like an MRI. Usually a CT would be fine. So, yeah. An experienced radiologist won't miss it, because when he gets to the soft tissue portion of reading the x-ray systematically, he'll say, wow, there shouldn't be that fluid there, and it has the same intensity as blood usually as it shows up on an x-ray, and that fat pad shouldn't be pushed way up like that. I need to go looking more carefully for that fracture, and again, he'll note this line here that shouldn't be here. So again, it just highlights the need to read systematically. Why do we look at the soft tissues? Sometimes we're looking for a specific soft tissue problem. An x-ray is just what's available to us, right? There are lots of ways to look at soft tissue. Ultrasound, CT shows you, MRI shows you, but we often can get a quick, inexpensive, relatively easy to get x-ray to look at some of these things, right? I mean, lung cancer on a chest x-ray is a good example. It's not the best screen for lung cancer, a chest x-ray, but certainly it picks up lots and lots of nodules that are not bone that flag us to go looking for something else. So always, always, always look at the soft tissues. Moving on, so get to the important stuff. So that's the tool. That's the systematic process that I do want you to know. Know what things you need to look at on an x-ray in order to make sure you've seen everything the x-ray has to show you. Be ready to be surprised at times by things you see, maybe foreign bodies, maybe masses and lesions you weren't expecting. But again, always look at the whole x-ray, everything that's in the picture, not just the area that you think you're concerned about. Look at that area for sure, but everything that's on the picture, look at it and make sure you don't miss anything. Okay? So, what are we looking for? Well, with bone, it's very often fracture, so it's really important to know how to describe a fracture. Okay? So in addition to just being systematic and describing everything you see in terms of the alignment, in terms of the joint spaces, in terms of the cortical integrity, in terms of the quality of the bone, in terms of the soft tissues, it will lead you very often to a fracture diagnosis. And so what do you want to note about a fracture? Well, in general, these things, and we'll go through some examples, but you want to note the direction of the fracture. Is it across the bone? Is it down the length of the bone? Is it kind of a spiral going down the bone? These kinds of things. You want to note, is the bone displaced or not? Like sometimes there's a fracture, but the bone is still in line like it normally would be. That is not displaced. But often, if you have a complete fracture, particularly, you'll have a shift in the alignment of the bone so that you don't have a normal straight line like you should in terms of the bony structure, and that's displaced. And we'll talk about how you describe that. Whether it's shortened or not. So sometimes when things are displaced, they may actually be pulled closer to the rest of the body. We call that shortening. And again, these are more complicated fractures, right? Angulation. So it's not just off to the side. Actually, the lower part of the bone is bent in a direction it shouldn't go. I toyed with the idea of including some pictures of horrible injuries, and I decided not to do that this early in the morning to you guys. But nonetheless, you will see people who come in and you say, wow, your arm is not going the direction it should go. That's an example of angulated fracture. Rotation. You might have that the lower portion of the bone is rotated slightly and the upper part of the bone is not. The upper part of the bone is still attached normally to its typical anatomy, whereas a fracture has allowed the lower part of the bone to be put under stress by the tendons pulling out from below, the ligaments pulling out from below, and it's caused a little twist of the bone, a rotation of the fracture. Distraction is when the two pieces of bone are pulled away from each other. And then impaction is where things have been pushed together. And you've got injury of the bone because things have been crammed together too much. Okay. So let's talk about a couple of these things. So direction. So the first picture here shows you a cross. We call that a transverse fracture. Okay, transverse. This is where all your medical terminology comes back into play. But it's important to use it. It helps, again, other people know what the x-ray showed when you describe it this way. It also helps an orthopedic doctor. So say you're on the emergency medicine service and you have a patient with pain, you think there's a fracture, you get an x-ray. You're going to have to be able to describe this to the orthopedic consultant so he'll know he needs to come see this patient and know how soon he needs to come see the patient. So you need to be able to tell him this is a transverse, in this case non-displaced fracture, so a relatively simple fracture. In this case, the second image is an oblique fracture. Oblique just means kind of like a diagonal fracture across the bone. And then this last one is a spiral fracture. And you can kind of even see that curvature, right? Sadly, these can occur for a lot of different reasons. In kids, one of the reasons they get a spiral fracture is abuse and like a twisting injury to their bone. And because their bone is a little bit soft, it'll fracture in that way. So just be aware that that's a really pretty gruesome, complicated fracture. And in children, unless there's a story, a history that makes sense of why they got that injury, you do have to suspect sometimes trauma inflicted by another person to them, okay? Let me say this also, just while I'm on the pediatric thing, I'm an internal medicine doctor, but I'm also a pediatrician. Most of what we're talking about, as with most of the things you talk about in class and clinical skills, they apply primarily to adults. Not all of the same rules apply to kids. Their bones haven't fully hardened, ossified, right? So it can be a little difficult sometimes to see fractures, or they can get some bending of the bone without an obvious fracture, what we call a green stick fracture, where it's just the bones are soft and so they can bend. But one of the things to note too is sometimes you'll have an injury and you'll think, oh, well, is it a fracture? Or did they sprain their ankle? Or in general, children do not sprain things, right? They don't generally get ankle sprains. So if you see a kid who has symptoms like an ankle sprain, think fracture. Think fracture. Get an x-ray. Why? So there are rules. In adults, we have what we call these Ottawa ankle rules, or in their other classifications too, where we decide based on history and physical exam whether I need to order an x-ray or not. Is there a high probability of fracture or not? In other words, what's my pre-test probability, to bring in some epidemiology and statistics, of a fracture in this patient? And is the likelihood ratio of the x-ray going to lead me to a better diagnosis than no x-ray? If the Ottawa ankle rules are used in an adult, you can decide reliably this person does not have a fracture. You can rule out fracture effectively by following these rules based on the history and based on the examination. In a child, they do not apply. Why? Because the child's bones are not as strong as the tendons and ligaments generally. And so rather than getting a tear of a tendon or a ligament, which might happen in a sprain in an adult, what you instead get is a fracture most of the time. Okay? So you're much more likely to get a fracture than you are a sprain in a child. So, in other words, don't avoid the x-ray in a child who might have an injury based on your history and physical diagnosis. You're just going to order more x-rays in kids than you are in adults because of that. All right, sorry to get off on that soapbox, but again, just an important thing to think about. And it just goes to show you the need for continually studying, continually learning, continually practicing as you go forward from here today. All right. So this is a terrible direction when we have what's called a comminuted fracture, right? So think of a puzzle, and then you take this nice puzzle that you've put together on the table, and then you just break it all to pieces, right, to put it away. Well, that's kind of this. There's a really terrible fracture that's caused the bone to shatter and to form many, many pieces. And so we call that a comminuted fracture. And again, it's like transverse, it's like spiral, it's like oblique. You want to be able to describe it to the consultant who you want to come see your patient. Or you want to be able to describe it to the senior consultant when you're on their service so that they know what type of procedure is needed to make this person better. Okay, so displacement, it just means that it's not in the normal alignment, right? The cortex and shaft are pushed to the side. And if it's displaced, you want to give it a percentage. So in this case, I might say it's 25% displaced. Okay? So don't just say it's displaced, say it's a certain percentage displaced. Well, how much area relative to the whole is it displaced by? In this case, maybe 25%, maybe 30%. You don't have to have the exactly correct number. You're not always going to measure it, but just give somebody an idea of how displaced it is, right? The more displaced it is, the worse it is. If it's completely displaced, and as in this case, nearly 100% displaced, you can say, okay, it's 50% displaced, but in truth, because the bone is beginning to migrate proximally and shortened, it's pretty much completely displaced in this case. So you could say it's 50% displaced and shortened. But again, you just want to describe those things because, again, the treatment varies depending on how severe the fracture is. And obviously, more displaced and shortened is worse than not displaced at all. Gotta hurry up. Okay, angulation. So, if something is bent a way it shouldn't go, you want to describe what angle. So in this case, maybe you say it's 15% angulated in addition to being a complete transverse fracture. It doesn't really look displaced or shortened, it's just angulated by maybe 15%. Again, the exact number is not important. You can get out your protractor if you want to measure the angle, but it's not too commonly done. Computers will do some of that to the radiologist. In this case, if it were angled away from the body or laterally, we call that valgus. I hate valgus and varus. They're really hard to remember which one is which. I remember valgus has the L in it for lateral. So if it's laterally angulated, that's valgus angulation. And then rotation, if it's twisted. And that's a little harder to see. You have to look at other bony landmarks to see if they have moved relative, and especially if you have two sides to compare, that's really helpful. You can tell if the head of the bone is rotated or not. But rotation, again, is a worse problem. You can kind of tell it's rotated here because you're seeing the fracture in a different profile that doesn't match the bone above it, right? So because of that, you're worried about rotation. So again, displacement, and all of these are different forms of displacement, but it's described how much it displaced, what direction is it displaced, is it shortened, Is it angulated? Is it rotated? Is it distracted? In other words, is it a wide space because the bone has been pulled away from each other? The two pieces have been pulled away from each other? Or is it impacted? And you might see this as a brighter white line because the bone has been pushed together, right? So the fracture is hidden in that injury zone right there. Impaction. All right, so it's a lot. So I'll publish all of this, like I said, on Moodle, so you guys can look over it again if you want to. There are other places to go online to practice. One of the sites I really like, whether it's chest x-rays or CTs or musculoskeletal films, there's a site out of the UK called Radiology Masterclass. And so a lot of the principles they're talking about are universal. Everybody talks about those principles. But I certainly looked at their materials and went through them for some of the images just to be able to highlight what we want to talk about today. But if you want more practice, that's a great place to go. Radiology Masterclass. Just put it in Google and it'll take you right there. But there are lots of other sites where you can go practice reading x-rays. So you apply the techniques we've talked about, use your systematic approach, you describe what you're seeing, and then you can look at the answer and see if you were correct or not. Okay? It's really helpful. Before I get to some examples, because we only have a few minutes left, like 2 minutes left, anybody have any questions up to this point? Yes? How do I put the fracture in terms of a percentage? So I usually do it relative to the healthy bone nearby. So say you can have a fracture that's complete, and that's all the way across the bone. Say you have a fracture that's partial, only part of the way across the bone. I could say 10% of the bone is fractured relative to the whole bone above it, that kind of thing. When it's displaced, I think that was pretty obvious, right? It's a certain percentage. When it comes to shortening, that's harder because it's going to be such a small percentage. So you can say it's shortened by a certain, maybe by a centimeter or two on the x-ray, that kind of thing. And then when it comes to angulation, we're going to measure, like I said, in terms of degrees of angulation. But in terms of a percentage, it doesn't have to be exact. You don't even have to apply a percentage. You can say partial or complete, severe, mild. All these words are okay too if you don't know a percentage, but it's good if you can to estimate a percentage. Does that kind of answer your question? Okay. We can talk more after if it wasn't clear, because I'm not sure I quite answered it. Okay. Let's go through a couple examples, maybe, if we can do it quickly. So in this case, again, it's easy to look and see, ooh, that's abnormal up there. But again, just go through the steps. We don't have patient data again, sorry. But you go through the steps, you make sure you look at the alignment, you look at the joint spacing, you look at the bone quality, you do the cortex to make sure it's all in line. And of course, it is not in this humerus fracture. How would you guys describe the actual fracture here? What do you think? So the direction is oblique, I think I heard somebody say. Yeah, that's probably right. Doesn't look really spiral. Oblique. What else? Displaced? Oh yeah, displaced severely, right? And in this case, it's laterally displaced, and it's probably more than 50% displaced. Okay? Is it shortened? Yeah, it looks like it is a little bit. It looks like that top tip of bone is beginning to migrate proximally, right? And then is there angulation? I mean, not really. It's pretty straight. Maybe there's a small amount, maybe 5% or less of valgus or lateral angulation. And then it's hard to tell because the film is small, but there probably is some rotation. And again, you can tell by looking at the top. It doesn't quite look like the pieces of the two bony ends match up, right? And that's always a clue that there's rotation as well. You can also tell sometimes at the base of the humerus if you're seeing a different profile of the head of the humerus. Okay, so that's a pretty obvious one, but again, you just want to practice using these skills to apply them. That's how you're going to learn how to describe things. So that this one's really obvious, some won't be as obvious, but as you label what you see, as you list what you see, you'll come to the diagnosis more often than not. So in this case, it's a pretty similar type of situation. In this case, we're dealing with the femur, not the humerus. But you have this fracture. But in this case, I want to draw your attention to the fact that you go through the patient name and data, that's correct. You go through the bone and joint alignment, well, that's clearly abnormal. You go through the cortical outline, etc., the soft tissues. But what you really notice is the quality of the bone before you get to soft tissue. It looks what we call moth-eaten. In other words, it looks like something's eaten little holes out of the bone. And this would be a classic picture for something like multiple myeloma, where the calcium has been resorbed from the bone, and you're left with these little holes, which is why this has been fractured. It's a pathological fracture. So you want to make note of the bone quality being abnormal, that this is a pathological fracture, in addition to it being a nearly 100% displaced transverse fracture of the femur with angulation and probably some rotation. It is shortened as well, right? So again, just something to practice. I'm sorry I'm going fast. My goal is to have more time to practice at the end. I think we're... Oh, okay, that's my signal that we're done.